Welcome to Uniquely Spoken Podcast, empowering healthcare, where transparency sparks transformation. Are you ready to dive into conversations that will spark ideas and inspire action? This is a podcast that refuses to accept the status quo. This is episode 13, Medication Safety at the Point of Care. What breaks for nurses and medication aides, and how to fix it in real time. This episode is educational and evidence-informed. It does not provide legal advice. Medication safety does not break when something goes wrong. It breaks in small, predictable ways, quietly, during the most routine moments of care. And that matters because in long-term care, medication administration is not a single task. It's a chain of tasks. It's a workflow. It's a system moving under pressure. And when that system is stressed by time, interruptions, staffing ratios, documentation burden, and medication conditions, risk doesn't disappear. It concentrates. Today's episode is for nurses and medication aides working at the point of care. Not in perfect conditions, real conditions. Because the reality is, medication administration remains one of the highest risk process across long-term care settings. And error rates during administration have been observed in a wide range in direct observation studies, including long-term care. So today, we are going to walk into the mad pass, not with blame, not with assumptions, but with clarity. We're going to name what actually breaks and what you can do in real time to prevent harm. Across this series, we've talked about the reality of missed doses and how medication management risk doesn't live in one moment. It builds across the entire process. We've talked about documentation pressure, how accuracy competes with time, and how the record can reflect strain rather than reality. We've talked about near misses and quiet failures, events that almost harmed someone but didn't, and how systems can't learn from what isn't captured. And we've talked about protecting staff through just culture and collaboration. Because when accountability becomes blame, silence becomes survival. We end it with the truth that systems must outlast individuals. Now, episode 13 brings it back to execution. What happens during the mad pass? What breaks and how we fix it at the point of care. This episode is not about policing anyone. It's not about shaming nurses. It's not about blaming medication aides. It's about predictable breakdown points, system failures that show up in daily work. Medication safety research consistently frames administration as one part of a complex process with many risk points, and emphasizes that system factors like distractors, convoluted workflows, and inadequate support contribute to medication administration errors. So here's how we're going to do this. I'm going to walk you through the 5 breakdown points, 5 places where risk enters the med pass. And I'm going to give you real-time operational fixes you can use without needing perfect staffing or perfect days, because perfection is not reality, but safe practices can substantially mitigate risk. Let's talk about breakdown point 1. The medication is not available or not usable. Let's start with a situation that doesn't get enough attention. Sometimes a medication is not available. It's missing. It wasn't delivered. It's late. It's back ordered. It was not ordered, or it's waiting for a prescription refill from the ordering physician. That's the obvious version. But there's another version that happens all the time, and the nurses and medication aides know it well. The medication is technically on the cart, but it's not usable. The cart is overstocked. There are several open packages. There are duplicates. Some packages are half used. Some are newly opened. Some are not clearly separated. And the longer that goes unmanaged, the harder it becomes to reorder on time, because the system can't easily tell what's actually needed. And that's where missed doses are born. Not always from absence, but from confusion and time loss. This matters because medication administration is already cognitively demanding. When you add a physical inventory problem to the point of care, you increase cognitive load and time pressure. 2 ingredients consistently linked to medication error risk. Now here's the operational truth. A cart that is full is not the same as a cart that is safe. And if you're working short-staffed, the system must become simpler, not more complicated. Because workload and staffing strain are repeatedly identified as contributors to medication error risk and unsafe conditions. So what do you do in real time? You don't need a perfect solution today. You need a safe response today. If you're digging through multiple open packages and you feel that search pressure, treat that as a safety signal, not normal workflow. Pause, recenter, because rushing doesn't remove the risk. It compresses it. And if you're in a role where you can escalate, flag the overstock and duplicate open package problem as a system issue. You must fix it or report it. Because if physical inventory and documentation don't align, discrepancies accumulate. And that can contribute to missed doses and confusion at the medication cart. Breakdown point 2. Let's talk about the video we just listened to or viewed, because it is a perfect teaching moment. The nurse is passing medications. A resident looks at the medication and says, "That medication looks different. I don't remember taking that medication before." That moment is not resistance. That moment is not inconvenient. That moment is a safety checkpoint. Medication safety is not just what clinicians do, it's also what residents notice. And when a resident questions something, it may be the last line of defense preventing a wrong medication, wrong dose, or wrong resident situation from reaching the body. This aligns with the reality that medication administration is a part of a complex system, and the 5 rights alone are not enough to guarantee safety without system support and verification processes and the time to properly prepare and verify medications. So, operationally, what do you do when this happens? You must slow the process down. You do not debate the resident. You validate the signal. You might say, "Thank you for telling me. Let's double check this," because the resident has given you the exact information you need. Something doesn't match expectation, and mismatches are where medication errors begin. And if you're thinking, "I don't have time to double check," I want you to remember something. Time pressure is real, but errors cost more time than pauses ever will. Medications.
Here you go, Mr. Wallace. Just this one first, all right? Little sip of water.
Goes down easier than last week. Thank you.
You're doing great. One more whenever you're ready.
All right, slow and steady.
Breakdown point 3: interruptions and conversation during the med pass. Now let's discuss the video we just watched or listened to. A resident is talking while taking medications. And this is where med pass risk becomes invisible, because what looks like a normal human interaction can become an attention splitting event. Interruptions are one of the most consistent system factors associated with medication administration errors. Research discussing interruptions notes that they are common in healthcare and have been associated with medication administration error risk. And one widely cited analysis explains that error risk increases with interruptions, with the risk of any medication error rising as interruptions accumulate. Now, I want to be very careful in how we frame this. Residents talking is not the problem. Residents asking questions is not the problem. The problem is a system that expects a nurse or medication aide to simultaneously manage relationship, conversation, interruptions, documentation, and high-risk preparation without protective structure and with unreasonable high resident to staff ratios. So what do you do operationally? You don't shut residents down. You structure the moment. You can say kindly and clearly, "I want to hear you, and I also want to keep you safe. Let me finish preparing this dose, and then I'm going to give you my full attention. Let me finish my medication pass, and I will circle back around to you and give you my full attention." That is not code. That is clinical safety. But remember to circle back and remain committed to what you are saying. Remember, medication safety depends on attention, and attention cannot be divided without risk.
How are you doing, Ms. Vero?
I'm doing all right.
I brought your medication.
That medication looks different. I don't remember taking that before.
Nurses, what would you do in this situation?
Breakdown point 4. Documentation timing creates safety gaps. Now let's talk about the piece people don't want to admit out loud. Documentation timing. When documentation is delayed, the accuracy and specificity of information can degrade due to memory limitations and workload, creating gaps in communication and increasing risk. This is not about effort, it's about reality. In long term care, you may have interruptions. You may have staffing ratios that force task stacking. You may have carts that slow down workflow. And documentation becomes something you do when you can. But here's the operational risk. When charting becomes retrospective reconstruction, the record becomes less reliable. Not because people don't care, but because the system required the nurse or medication aide to carry too much cognitive load. So, what's the real time fix? Micro documentation, not perfect documentation, not long documentation. Micro documentation, small, timely entries that reduce reliance on end of shift memory to show you have passed or prepared a medication. Electronic health records that reduces time consumption to document medication management. This aligns with your earlier episodes on documentation pressure and the strain that distorts the record. Breakdown point 5. Near misses disappear and the system never learns. Now we get to the quietest breakdown point of all, the near miss. A near miss is an error that occurred but did not result in harm because it was caught in time, and it reflects underlying risk with value for reporting and improvement. In long-term care, there are institutional barriers to reporting adverse events, and near-miss reporting has been described as a strategy to reduce these barriers and support prevention. So let's connect to this with our 2 video moments. The resident said, "This looks different." That was a near miss. Imagine if this resident had some type of cognitive deficit or really just not paid attention to the medications because they trust and have built a rapport with the nurse or medication aide passing their medication. A near miss. Resident talking during med pass and attention splits. That can cause a near miss. That could be caught at the last second. And if nothing is captured, no learning occurs. Near misses need to have a safe, reportable system. It helps identify potential risks that are resulting in alarming outcomes. Unfortunately, the system doesn't get safer. The system doesn't get safer. It just gets luckier until it doesn't. So operationally, what do? You treat near misses as data, not confession. You frame it in just cultural terms: learning without punishment, accountability without blame. Because if near misses become punishable, staff will stop or continue or fail to report, and silence exists or returns. Now, let me put this together as one real world sequence. because this is how risk actually happens. A medication aide or a nurse begins a morning pass. The cart is overstocked. There are multiple open packages of the same medication, and it takes extra time to confirm what's current. Staffing is tight, so every minute matters. A resident begins talking while medications are being prepared. The nurse or medication aide is listening because residents deserve to be heard. And at the same time, attention is split because the process requires focus. Then the resident looks at a pill and says, "That looks different. I don't remember taking that before." Now, this is the pivotal moment. In a fragile system, that moment becomes pressure. I need to keep moving. In a safer system, that moment becomes protection. We're going to verify. So the nurse or medication aide pauses. They confirm the MAR. They check labeling. They verify whether there was a substitution, a change in packaging, or a new order. They complete the dose safely, or they hold it and escalate appropriately if it cannot be confirmed. That is not slow work. That is safe work. And here's the critical system takeaway. When staffing ratios are strained, the system must reduce friction at the cart, reduce interruptions during preparation, and reduce the documentation burden that forces memory-based charting, because workload and system stress are repeatedly linked with medication safety risks that are also resulting in legal litigations, with nurses and medication aides being a part of the lawsuit. I'm not saying this to scare anyone, but it is the reality. You must take your time and make sure that you are managing medications safely. It is okay to say to a resident that you can't talk right now and that you will come back to them when you give them full attention. But make sure you follow back up. If a resident questions a medication, you should never dispute their questions. And ironically, some residents may dispute it each time. So put a system in place that when you go in that resident's room and you know they are going to question it, that will reduce time delays and constraints. Let me close with this. The two video moments that we listened to or viewed, the resident noticing a difference and the resident talking during administration, are not rare events. They are actually everyday events. And everyday events are where safety is either built or lost. So here is your real world action step for this week. The next time a resident says, "That looks different," treat it as a safety signal. Pause and verify. The next time conversation pulls your attention mid-pass, structure the moment. Finish preparation safely, then return fully. And the next time cart conditions slow you down, overstock, multiple open packages, unclear reordering, missed medications, stop treating it as normal. Name it as risk. Escalate it as a system issue. Because systems don't learn from what we tolerate in silence. They learn from what we capture, correct, and redesign. If you are doing your best in a strained system, that is not failure. That is exposure. and you deserve a system that protects you while you protect residents. Remember, if you allow the medication cart conditions to remain the same, if you fail to check a resident's medication when they question it, if you allow a resident to be a distraction that results in an error, then you can find yourself in a legal situation. Keep in mind, only you went to school to get your license. Only you studied to become a medication aide. And only you can be the underlying cause for losing your licensure and your certification. The time to slow down, the time to think about best practices when it comes to medication management is today. It is now. It is not time to run from long-term care and the residents. And if you don't feel safe having a voice, submit an anonymous letter with your concern. Protect you and those you have chosen to provide quality care and services and ensure their safety. Thank you for being a nurse. Thank you for being a medication aide. Thank you for learning now to have a voice. Thank you for everything you do. And join the conversation. Partner with Uniquely Spoken Podcast. Help us make a difference for you. I am Juanita, the founder of Uniquely Spoken LLC. I started this podcast to ignite change in healthcare, starting with long-term care settings. It is time to transform nursing homes and rehabilitation centers, assisted living, and memory care communities to all become premier long-term care settings nationwide. It is time for all long-term care settings to receive a 5-star quality and customer service rating. It starts now, and it starts with me. It starts with you, and you. And the time is now. Thank you for joining us. We broadcast every Tuesday at 8:30 a.m. Eastern Standard Time. Don't forget to join the conversation, request to be a speaker, and partner in transforming long-term care settings. And don't forget to tune in next week. Thank you for joining us on Uniquely Spoken LLC podcast. Please subscribe on Spotify, Apple Podcasts, or wherever you listen. Remember to connect with us. Follow, comment, subscribe, share, be a guest. Visit us at uniquelyspokennllc.com/podcast. That's UNIQUEELEESPOKENLLC.com/podcast. Or if you are a viewer, scan our QR code. Please remember to stay informed, stay empowered, and keep the conversation going. We love hearing from you, and we'll see you next week.